changed over time, to think about the number of risks that are associated with prolonged bed rest and immobility, and to think about which patient groups are most at risk of these consequences. So just to begin, let's take a quick look at how mobility in healthcare has evolved. So before the 20th century, bed rest was a go-to treatment for everything, with the belief that resting the body will heal itself. Moving into the early century, this mindset continued and bed rest was still widely prescribed, with the belief that movement might worsen illness or injury. But by the mid-century, we started to see a different story. We began to see clear harms from immobility, such as muscles wasting, blood clots, chest infections, and pressure ulcers. We then saw a change. So in the 1980s, women were started to be encouraged to mobilise soon after childbirth, and post-op patients were up and walking soon after surgery. And this paved the way for the rest of the century with the rise of early mobilisation, which was supported by evidence that it reduced hospital stays, improved outcomes, and improved recovery. And today, early mobility is the gold standard for recovery. It's supported by a breadth of research, which we'll shortly hear about, showing that it's not only safe and feasible, but it's an important part of what we do. Okay, so I'm going to talk about the different systems that are most affected by immobility, starting with the muscular system, which is one of the main systems affected. So the main thing that happens to muscles is that there is a loss of muscle mass, which you can see in the image of the healthy muscle and the one that has atrophied. And this happens because protein breakdown outpaces protein synthesis. So basically the body is breaking down muscle faster than it can rebuild it. Muscle wasting can happen pretty quickly when people are unwell, and we see it all the time in hospitalised patients. And on critical care, this is even more extreme. For patients on critical care, they can lose up to 2 to 3% of muscle mass per day in the first week, which accounts for a massive 20% in just the first 7 days. We also see changes in connective tissue, making muscles and tendons more stiff and less flexible, which increases the risk of contractures. And lastly, because the muscles aren't contracting and aren't using their usual energy sources, these sources start to become fat instead. So we're basically left with wasted, weaker muscles that don't use their energy very efficiently. And onto the skeletal system. So when a patient isn't up and moving, the mechanical load on the bones is lost. This not only reduces bone formation, it actually accelerates bone breakdown. And this happens because the activity of the bone building cells reduces and the activity of the bone breakdown cells increases, a bit like what happens with the muscles. And as a result, bones become less dense and more porous, and they start to fill with air pockets. And the longer that someone is immobile, the greater this bone loss is, and the more at risk they are of developing fractures. We also see ligaments lose collagen and cartilage starts to break down, leading to joint pain, joint stiffness, and even long-term degenerative joint diseases like osteoarthritis. And if we think about somebody that's in pain, they're probably going to want to stay in bed and not move. And therefore, this cycle perpetuates where the pain is causing more immobility, the immobility is causing more pain, and so on. And this cycle is really difficult to break. So onto the circulatory system, so our heart and our blood vessels. So in a healthy, mobile person like you and I, our hormones tightly regulate our fluid balance. But just after 24 hours in bed, up to a litre of fluid can shift from the lower limbs up into the chest. And this triggers a whole host of responses, which ultimately increases our urine output and makes our blood volume reduced. This makes the blood more thicker and more prone to clotting, so patients are at increased risk of deep vein thrombosis and pulmonary emboli, which can be really life-threatening. We also get something called venous stasis. Because the muscles aren't moving and pumping blood back to the heart effectively, the blood starts to pool in the veins, especially in the lower limbs. And if we have a reduction in the blood returning to the heart, this means that less blood is ejected per beat. And we can see stroke volumes drop by about 30% during bed rest and immobility. But what the body will do, it will try and compensate by increasing its heart rate to maintain its cardiac output. So we can also see changes in resting heart rate by about 10 to 15 beats per minute. So we have long-lasting physiological changes actually happening. And we also get something called orthostatic hypotension, which can become a real problem because the cardiovascular system just becomes really sluggish and intolerant to adjusting to position changes. And patients can become really dizzy or faint. And we often see this when we're first getting patients up on the edge of the bed. They become really symptomatic with their dropped blood pressure, and we're often having to return these patients back to bed. So onto the respiratory system. So we have a lung volume called functional residual capacity, and this is the amount of air that's left in the lungs after a normal breath out. And it's a really crucial lung volume in keeping our airways open. But as we age and when we're lying in a supine position, this capacity can decrease, making it harder to keep the airways open. And what happens when we're breathing out is that these small airways start to collapse down. So there's a higher risk of atelectasis where parts of the lung can collapse. And if we have parts of the lung that have collapsed, this significantly reduces our surface area for gas exchange, which can significantly impair oxygenation. We also see drops in tidal volumes in the supine position, and this happens because the ribcage movement is restricted and the abdominal contents impede the function of the diaphragm. Secretions can become also a major issue as they start to pool in the airways. This increases the risk of serious chest infections and further lung collapse. And clinically, what this means is that patients can remain longer in hospital, they have a much higher risk of mortality, and they can experience really distressing breathlessness. And if you think about somebody that's breathless at rest, the last thing they're going to want to do is exert themselves, make themselves more breathless, which can be a really frightening experience for patients. And again, this perpetuates that cycle of immobility, causing these consequences and making everything a lot worse. The neurological system, so our brain and our nerves. So prolonged bed rest can actually compress the nerves, leading to nerve damage, sensory loss and muscle weakness. And in critical illness, we get something called polyneuropathy, where nerve damage and muscle dysfunction is so profound. Immobility can also affect our coordination and balance, increasing the risk of falls and reducing independence in daily activities. And bed rest can also lower serotonin, contributing to mood changes like depression and anxiety. In the brain itself, we see changes in neurochemistry, metabolism, and neuronal activity, which can trigger delirium. Delirium is characterised by confusion, disorientation, and fluctuating alertness, which can be really distressing for patients. And the aftermath of delirium can be really life-threatening and detrimental, with some really significant long-term impacts, not only for patients themselves, but also for their loved ones. Okay, down to the gastrointestinal system. So immobility itself slows gut motility, meaning that food and waste move more slowly through the gastrointestinal tract. And what this slow movement does, it allows more water to be reabsorbed, eventually resulting in hard, dry stools that are difficult to pass. This can cause fecal impaction and increase the risk of fecal incontinence. And chronically, patients that are constipated can develop these balloon-like pouches in the colon called diverticula, which can cause bowel obstructions. Patients that have bowel obstructions are at higher risk of bowel perforation, and some patients might even need to have surgery to rectify this. In the stomach, we have delayed emptying, and lying flat can cause acid to pool in the stomach. And this can damage the sphincter that separates our esophagus with our stomach. And this can increase the risk of reflux, regurgitation, aspiration. And patients that do aspirate their stomach contents are at high risk of aspiration pneumonia, which can be life-threatening. Okay, into the renal system, so our bladder and kidneys. So in an upright position, gravity usually helps urine collect at the bottom of the bladder, which stimulates our urge to urinate. But when we're supine, this this urge to urinate is reduced because we're in the supine position. So urine sits stagnant in the bladder and increases the risk of urinary tract infections. If urine is retained in the bladder, it can become stretched, and the stretch receptors lose their sensitivity, potentially leading to urinary incontinence. Kidney stones are another risk. Prolonged bed rest leads to elevated calcium from the bone loss, which we've talked about, and increased urea from the muscles breaking down, which we've also covered, both of which can contribute to stone formation. Anybody that's had kidney stones, I hear, it's very, very painful. People that are in significant pain, again, will want to stay in bed, not move, and this further escalates the problem. And we also see a loss in electrolytes, particularly sodium, potassium and calcium, which can be really dangerous for our overall physiological function because a lot of our vital body functions rely on these important electrolytes. And the last system, the integumentary system, and the biggie here is the skin. So we regularly shift our weight without even thinking about it, which prevents prolonged pressure on one area of skin at any one time. But patients that are immobile can't do this. So the capillaries get compressed, which cuts off important oxygen and nutrients. This can lead to pressure ulcer formation and makes the skin more fragile and prone to tearing. And if patients have pressure ulcers and skin tears, these wounds can become easily infected and in severe cases lead to tissue death, which you can see on the last image, the black part, and also systemic infection where patients can become really unwell. So this slide just shows the patient groups that are most at risk of these consequences of immobility and bed rest. And what we should be doing is considering early mobilisation for all patients, irrespective of their age, their morbidity status, or in fact of the ward that they're on. But actually what we should be doing is prioritising these patients because the consequences are so detrimental to these patient groups. We should be focusing our early mobility interventions to these patient groups. So hopefully I've explained how immobility profoundly affects nearly all systems of the body. And promoting early mobilisation can and does mitigate these risks. And there's really an importance around preventative medicine as opposed to curative medicine. It's a lot easier to try and prevent some of these consequences from happening rather than trying to treat the consequences when they have happened. And it's imperative that we as healthcare professionals do this to minimise the serious health risks, the poor recovery and the long-term issues as a consequence of bed rest and immobility. And I'm just going to leave you with this really nice quote. Thank you for listening.